So I'm going to talk about processes to reduce medication errors in the ICU. And we know that the ICU can be a high-risk environment and our patients are vulnerable to errors. To respond. So we know it's a high-risk environment, and our patients are vulnerable to iatrogenic harm. There's been one study that looked at, an observational study that looked at errors over a one-year period, and they found that 3/4 of the serious incidents and errors were medication-related. So I think it is worthwhile looking at various strategies that are out there to minimize these errors. So I think it's useful to characterize the key stages of the medication process. And from the general board literature, we can see that most of the errors occur predominantly at the preparation and the administration stage, but also prescribing and as patients transition from one phase of care to another. And here I've outlined the key processes that can reduce error focused on these various stages. And in the remaining time, I'm going to hone in on a few of these. I think it's worth highlighting that specialist clinical pharmacists review at ward rounds and integrated into the multidisciplinary team, and also learning from critical incidences and near misses with a multidisciplinary approach can have an effect at all these different phases of the process. But first, looking at prescribing. So we did one of the very early studies, which was a transition from handwritten prescribing to electronic prescribing. And we found that once the system of electronic prescribing had a time to bed in, then there was a significant reduction in prescribing errors. But new types of errors were introduced, and the severity of these errors, some of them were actually more serious than those that we saw with handwritten prescribing. So that's something to bear in mind. I think also there is a concern that some of the ICU standalone electronic prescribing components as part of a wider ITU system lack some of the basic functionality that we should expect, such, for example, as allergy alerts. We did a study in the UK in 21 ICUs over a 2-week period where we looked at the errors and contributions from clinical pharmacists. And with regard to the errors, we found that they detected just under 7% of all prescriptions had an error, which is 1 in 15 prescriptions. And indeed, in a systematic review and meta-analysis, it was reported that pharmacists integrated into MDT teams and part of the rounds were associated with the patients in the ICU having a reduced mortality, a reduced length of stay, and also reduced incidence of adverse drug events, both preventable and non-preventable. So now moving on to preparation and administration phase. So the incidence of errors in this phase is a bit variable from the literature. We've got 2 studies that are quite similar. They report 7% and 6.6% errors, but another study that reports 33%. The Sentinel study was a 24-hour snapshot of parenteral errors in international practice. And it reported that nearly 20% of patients in that 24-hour period experienced 1 error, and 14% had 2 or more errors. And in terms of severity, 28% suffered a temporary change in their status, and 7 patients experienced either permanent harm, and 5 sadly died. So how reliable is on-ward or on the ICU drug preparation? Several studies have highlighted the variability of what is prepared on the ward compared to what is actually prescribed. An example here in relation to magnesium infusions, but there are many other examples, such as acetylcysteine here in the emergency department, opioids prepared in the pediatric ICU, and another scenario-based study involving morphine calculations and preparation. So this makes quite disturbing reading. What can we do about it? I'll outline a few solutions. In the UK, the National Patient Safety Agency published a risk assessment tool to risk stratify high-risk preparations. And in our country, we were tasked with reducing all high-risk preparations. And so in this example, this is for norepinephrine made from ampoules, and this is classified as high risk. And if we were to introduce ready-to-use syringes or vials, then we can mitigate that and reduce that to a moderate risk. Also, work by the UK Critical Care Clinical Pharmacists Association Critical Care Group, working with the Intensive Care Society, produced a standard solution table of common infusions. And familiarity with this list is useful for practitioners moving between units, but also for manufacturers who are looking for a market for ready-to-administer products, if everyone's using the same concentrations. What about smart pumps? These are pre-programmed infusion devices introduced to address the human factors involved in pump errors. The evidence is not so conclusive that these reduce errors. The evidence is better when hard limits are pre-programmed that cannot be overridden. There's a huge infrastructure that needs to go around these pumps, which maybe sometimes is under-recognized. What about the double check at the point of IV preparation? Well, again, the evidence around the benefit of a practitioner double check is not strong, perhaps because that check becomes a matter of routine and diffuses responsibility between the two practitioners. To finish off, I'm just going to say a few words about transition of patients as they move into the intensive care and out of the intensive care, and particularly around medicine reconciliation. So increasingly, our patients are established on very complex regimens before they come to the intensive care. And often it's not a simple thing to actually establish exactly what these patients take in their regimens. And so several sources need to be consulted to establish their regimens. And in the UK, this is undertaken by pharmacy technicians routinely. And so these meds can then be reintroduced accurately, often within the intensive care stay. I think more of an issue, at least for us, is on ICU discharge, because often ITU drugs, which are started in intensive care, are inadvertently continued as the patients leave intensive care onto the ward, and then potentially even as they go home and are discharged from hospital. What can we do about that? Well, staff education and guidelines can improve the deprescribing of inappropriate meds by fourfold. And I think that's a work in practice, still not established in our practice. So in summary, I think we can say that medication errors are common in the ITU, particularly around the IV preparation and administration, but also around prescribing and as patients transition in and out of intensive care. There's no one thing which is going to mitigate against all these different types of errors, but a bundle of approaches are going to be needed. And I think it's important that incidents and near misses should be continually reviewed by multidisciplinary teams with the power to act and disseminate the solutions to the wider team. And so I've presented a summary of many of the processes to address these medication errors. Not time to go into detail, but thank you for giving me the opportunity and for listening. Thank you.